Ladies and gentlemen, please join me in welcoming Dr. Richard Horowitz.
Thank you, everyone. It's really a great pleasure for me to be here, especially because Europe, for me, is my second home. I did my medical training in Brussels, Belgium, between 1987 and 1994, so I had a chance to come to Scandinavia at that time. And my medical training in Europe really taught me well because when I came back to the States, I did my training at Mount Sinai in New York City, and then I moved to a part of New York called the Hudson Valley. And what I didn't realize when I was finishing my medical training is I was moving to the highest Lyme endemic area in New York State and almost in the United States. So when I opened up as a board-certified internist, I'd seen approximately 3,000 patients, internal medicine patients, but patients started coming in with Lyme disease, with the bullseye rash, and approximately 75 to 80% of these patients would get better with 30 days of doxycycline or amoxicillin. But about 20 to 25% would go on to chronic illness. And I decided that it was my job, and really the job of all physicians, to figure out why these patients remain chronically ill. So in the last 27 years, as Kathy had said, and I'd like to thank Steve and Kathy for helping to host this conference. It's a wonderful opportunity. I tried to figure out why these patients are ill. And there's a map that I'm going to share with you primarily tomorrow called MSIDS, Multiple Systemic Infectious Disease Syndrome. And this explains why many of these patients remain chronically ill. And what I'm going to discuss with you this morning is just 1 point out of 16 on the MSIDS map, which is co-infections. And I will tell you that the majority of the patients who come to me from Norway, who come to me from France, from Belgium, from other parts of Europe, one of the main reasons they have not gotten better are tick-borne co-infections. And the problem is that many European doctors are not testing for these co-infections. And just recently, in the last 3 or 4 months, several of the Norwegian patients who came to see me tested positive for Babesiosis, specifically Babesia wa1 duncani, which was not picked up. And the same thing in the French patients. And once I started treating these patients, they'd been sick for 13 years, some of them. Within 1 month, these patients were significantly better, simply by treating the malarial parasites. And the reason I learned about these co-infections is because many years ago, it was about the late 1990s, a patient came to me who was in a wheelchair. And she was 31 years old, and she had drenching night sweats. And I looked for causes of why she had these drenching sweats. I ruled out tuberculosis. She didn't have a cough. She did not have non-Hodgkin's lymphoma. There were no enlarged lymph nodes, and there were no mediastinal nodes on a chest X-ray. She didn't have brucellosis. Her FSH and LH were normal. She did not have any hormone abnormalities. She'd never traveled outside the country for malaria. And in fact, we discovered through IGNX laboratories, through FISH and PCR testing, that she had Babesia, but it was not supposed to exist in the Hudson Valley where I was. And this woman was in a wheelchair for 6 years, unable to walk. She cost New York State over $500,000 in disability. And within 10 days of treating her for Babesiosis, with Mepron, atovaquone, and Zithromax, she walked out of her wheelchair for the first time. And she's been skiing ever since. There are other patients who come to me, 36-year-old woman who is unable to speak. She had no words, completely aphasic, for several years. She had been to Harvard. They told her it was atypical migraines. MRI showed some nonspecific demyelinating lesions, but no one could figure out why she was sick. She eventually tested positive for Bartonella by PCR. And even though I had treated her with every Lyme regimen we used as doctors, when I finally gave her a quinolone drug, Cipro, Levaquin, Avalox, Factive, within 1 month, this woman started talking for the first time in 4 years. I have these type of cases in my practice where we're finding the tick-borne co-infections, Babesia, Bartonella, and especially Mycoplasma species like Mycoplasma fermentans are causing tremendous inflammation in the body. And if you want to understand why many of these patients are sick, and you look at the medical literature, what you discover is that many of these infections cause inflammatory cytokines to be produced. Tumor necrosis factor alpha, interleukin-1, interleukin-6. When you get these inflammatory molecules produced in the body, whether it's through Lyme disease or through co-infections, or because you're not sleeping at night and your interleukin-6 levels are high, or because you have a zinc deficiency, which drives up inflammatory cytokines, or you have heavy metals or environmental toxins, no matter what the cause of the inflammation, it causes exactly the same symptoms, which is fatigue, joint pain, muscle pain, tingling, numbness, neuropathy symptoms, memory, concentration problems, psychiatric symptoms, difficulties with sleep. These are all caused by inflammatory cytokines. The problem is that there are many reasons why people have inflammation in the body. And I'm going to discuss this in detail tomorrow, but today what we're going to discuss is mainly how tick-borne co-infections are causing inflammation and causing many of these patients to be ill. Now, I was driving through Connecticut recently, and I took a picture, and we asked ourselves, well, the epidemic in America has gotten so bad that now they're naming towns after people with Lyme disease. So, for example, you can see here that Chester had Lyme, and Martha had Lyme, and Richard had Lyme, and everyone's getting Lyme at this point in the United States. We're naming towns after them at this point. So you must understand, first of all, that it's a worldwide epidemic. In fact, it's the #1 vector-borne spreading epidemic worldwide. I was called by the Chinese government 4 years ago. I was lecturing in Toulouse. Dr. Christian Perun had invited me to speak at an infectious disease conference in Toulouse. And I got a call from the Chinese government that they thought they were discovering Babesia, but it wasn't fitting the classical patterns. There was no hemolytic anemia. There was no thrombocytopenia. There was no elevated liver functions. So I brought Dr. Shah and IGeneX over there, and we spent 1 week in China speaking to their CDC and their government officials, and we showed them with the FISH test, the fluorescent in situ hybridization, that the RNA that they were finding was in fact a Babesia species. But because Babesia, when it's associated with Lyme, doesn't necessarily cause the same symptoms you read about in the textbook, and this is what you need to understand. Lyme with Babesia, with Bartonella, with these co-infections, you get subclinical presentations. It's not what you're going to read about in the textbooks all of the time. So this model for chronic disease called MSIDS, basically a model where we have found that there are multiple overlapping factors that are causing many of these people to be sick. What we're finding now is that there's a multifactorial which is causing inflammation in the body. So the advantage of the model that I'm discussing with you is that if you have multiple factors causing inflammation, these same inflammatory molecules will cause symptoms, but if you don't get rid of all the causes of inflammation in the body, these people will remain chronically ill. So we really need to redefine what we're calling chronic Lyme disease, because what I'm seeing is more Lyme MSIDS. I'm seeing at least 16 different reasons why people are staying sick, and tick-borne co-infections, many of the bacteria I'll talk to you about today, parasites like Babesia, and viruses are often responsible for a lot of these resistant symptoms. And when we treat what I call the 3 I's, infection, inflammation, and immune dysfunction, in a comprehensive treatment plan, we find that the majority of these patients will get better, but you can't just treat the Lyme. You have to treat the co-infections and all the sources of inflammation in the body, which again, I will be discussing tomorrow in greater detail. Now, as far as the tick-borne co-infections go, you heard earlier that there are many borrelia species that are starting to come out, including relapsing fever, Borrelia hermsii, and Borrelia miyamotoi. Dr. Shah told you there were only 3 confirmed cases of Borrelia miyamotoi. Well, I just got my 4 months ago in patients. I had a psychiatric patient. He was extremely ill with psychiatric symptoms. He had been on 5 months of antibiotics for Lyme, and he had a positive PCR for Borrelia miyamotoi in his blood. We're finding the same type of PCR studies in many of the patients where Lyme, Babesia, Bartonella, other Borrelia species like miyamotoi, and Mycoplasma species like Mycoplasma fermentans are all showing up as chronic persistent infections when these infections are mixed together and they're suppressing the immune system. So then there are bacteria such as Ehrlichia Anaplasma, parasites like Babesia. Babesia microti was the first one we discovered, but as I'll show you, in my area of the United States, up to 19% of the patients I test for Babesia Wa1 duncani are now positive through standard labs like LabCorp. And we're also finding at this point that there is an occasionally Babesia divergens even in the United States. But the problem with Babesia is Babesia suppresses your immune system for getting rid of not only Lyme, but other parasites. So Krauss, when he published in 1996 in JAMA, what he found is patients with Lyme and Babesia were 3 times sicker than patients who just had Lyme alone. And you could find the PCR Borrelia burgdorferi in the blood 3 times more frequently. And what we find with Babesia in the medical literature is you have a much more difficult time getting rid of other parasitic infections when you have Lyme and Babesia. So for example, we find a lot of toxoplasmosis. There's another parasitic infection, FL1953, Protoxoa rheumatica, which has now been discovered to be 8 different parasitic species that are showing up in patients with Lyme disease. And we're finding intestinal parasites, amoeba, giardia, schistosomiasis, amoebiasis, different parasites that are showing up that the body is unable to clear when you have Babesia. And then when we treat with drugs like ivermectin, biltricide, Flagyl, tinidazole, Alinea, albendazole, antiparasitic drugs, many of these patients who don't get better with Lyme get better with antiparasitic treatment because Babesia has suppressed the immune system and there are many other parasites in the body which sometimes have nothing to do with their initial tick bite. You have to look at the terrain of the body and what has happened to the body in other infections when Lyme and other tick-borne infections get into the body. We're finding Bartonella, multiple species, Mycoplasma, like Mycoplasma fermentans, which causes autoimmune reactions. I'll show you the scientific studies that Mycoplasma will cause positive anti-nuclear antibodies, positive rheumatoid factors, and overstimulates the immune system just like Lyme does. So you could believe that these people had an autoimmune reaction. Now, there's no doubt that Lyme causes an autoimmune reaction. Alan Steer is absolutely correct. There is molecular mimicry. When your immune system is trying to kill borrelia and go after the flagella, that 41 band on the Western blot, for many people it goes after the myelin sheath and demyelinates. And that's why up to 70% of the people will get demyelination. There is an autoimmune reaction, but we find that there are many factors driving demyelination. In MS, it's been discovered that chlamydia pneumonia has been associated, vitamin D deficiencies. Mercury can act as a hapten on the outside of cells, causing up to 800 autoimmune reactions. And yet none of these were addressed in the double-blind placebo-controlled studies done by the NIH. So you must realize that there's a lot that is in the scientific literature that has not been accounted for in many of these patients that are remaining chronically ill with Borrelia. And we're finding a tremendous amount of rickettsial infections, Rocky Mountain spotted fever, especially Coxiella burnetii Q fever. Some of my patients from France who have come to me have tested positive for Q fever. And it can cause a chronic endocarditis, and it can be very, very dangerous. We've picked up cases of Tularemia, Brucellosis, and then there are viruses now in the ticks, like the Heartland virus and Powassan virus, which can be deadly in 10 to 15% and sometimes into 30% of the cases. So with one tick bite, you can get multiple infections. Now, do we have multiple infections in the ticks? Well, yes, we do. In this first study that was published by Tokars in 2009, he showed that 71% of the ticks had one organism, 30% had 2, and 5% had 3. And you'll notice even going back several years, we were finding borrelia miyamotoi, this relapsing fever spirochete, in 10 to 20% of the ticks in the Northeast, and the standard blood tests will not pick it up. In Europe, they found in Ixodes ricinus ticks a high amount of Bartonella in the Netherlands in 5 to 10%. Liebach had found piroplasmosis, Babesia Wa1. And again, several of my French and Norwegian patients have just tested positive for Babesia duncani Wa1, and it was the main reason they stayed sick, is this parasite was keeping them chronically ill. And then there's tick-borne encephalitis in Europe. As Dr. Shah told you, there are a lot of different Bartonella species. We're picking it up in the white-footed mouse, Paramyscus leucopus, with Borrelia burgdorferi and Babesia in the Midwest. In New Jersey, it's showing up in patients in their central nervous system. I had a patient with a transverse myelitis. He had seen 8. Why? He was sick and he could not walk. We did a spinal tap. We found Bartonella PCR transverse myelitis. Once we gave him Rocephin with Bartonella treatment, like doxycycline and rifampin, he walked for the first time. And in Brian Fallon's study, which is the NIH double-blind placebo published in Neurology in 2008, what they found is up to 60% of people in that study, including controls, had Bartonella henselae. So Bartonella is one of those species that's showing up quite frequently now in the ticks. And Dr. Shoppe and I were working on a study, it's not yet been published, but she found Mycoplasma in the ticks, Mycoplasma genitalium, Mycoplasma fermentans, Mycoplasma pneumoniae. So you can get Mycoplasma species also causing immunity, inflammation, and autoimmune reactions in some of these patients. And I'm finding that the majority of my patients, the reason they don't get better is they're multiply co-infected with all the other reasons that I'll show you tomorrow that cause inflammation. Now, there are many rising incidences of Borrelia infections. In the 1990s, we found 7 new species and 8 more in 2000. And not all of these are going to be picked up by standard testing. So although acrodermocritis chronicum atropicans is called by Afzelli and Guarini is neuroborreliosis, we know that Borrelia spilmanae can cause early skin disease, but there's also Valsina and Lusitania, maybe associated with some of the vasculitis that's seen in Europe. And then there are many species in Asia. In the United States, Kerry Clark discovered in Florida, they thought they did not have any Lyme disease and then discovered that in fact, Borrelia andersoni and americanum, other Borrelia species were showing up, causing Lyme-like symptoms in these people, but they were negative on the standard 2-tiered testing. And recently, in Mendocino County, California, Borrelia biseti has been implicated as a new human pathogen. So co-infections are on the rise. The Powassan virus was 1 to 2% in the ticks in my area several years ago. It's now 5 to 6% of the time being found in infected adults. In Vermont, they have EEE, equine encephalitis virus, in 10% of the deer ticks. And now 16% of the dogs have serological evidence of Lyme. It was only 10% years ago. This is by the Vermont Department of Health. The incidence of anaplasmosis doubled in the last several years in Vermont. And now we're finding with Borrelia miyamotoi, this new relapsing fever, 4% of the patients in New England are testing positive. So we have 100 different species of Borrelia in the US, 300 species worldwide, and it's the first Borrelia species to be transmitted transovarially. So here is where the problem lies. The tick does not need a blood meal to feed off a mouse or a deer. The mother tick can transmit this particular spirochete, and it's been found in 6 to 73% of the larvae, which means that if you think the Lyme epidemic is bad, this epidemic with Borrelia miyamotoi is probably going to surpass Lyme in the next 10 to 15 years because mother ticks are transmitting it directly into the larvae without blood meals. So the prevalence is now at least 3.6% in the ticks, and in California, they recently discovered in Ixodes pacificus in the San Francisco area that Borrelia miyamotoi was as abundant as Borrelia burgdorferi. So although we normally think that we get Lyme disease, Ehrlichia, Anaplasma, Babesiosis, we now need to include Borrelia miyamotoi as being as frequent a co-infection as many of the other ones that we're seeing. This study, this was just published just 3 weeks ago online by Yale University researchers, that 4% of people in southern New England tested positive for Borrelia miyamotoi, that 2 to 10% of all the ticks that transmit contained Borrelia miyamotoi, and that the antibody test for Borrelia burgdorferi was not able to pick up all of these cases of Borrelia miyamotoi, yet it was causing a Lyme-like illness. And this would explain some of the controversy of why people have Lyme-like symptoms, where they have good and bad days. And some days they have a pain in one joint, and 3 days later it migrates into another joint, and 4 days later it's in another joint. This migratory joint pain is very classic for Lyme disease. And they have tingling, numbness, and burning. Comes and goes with good and bad days. And this neuropathy also migrates around the body. You don't see migratory myalgias, arthralgias, and neuropathy in any other disease. That is one way clinically you know you have Lyme. And women will tell you right before, during, or after their menstrual cycle, they're much worse. If you take antibiotics, you may find for urinary tract infection, if you didn't know you had Lyme, you get much better or much worse from a Jarisch-Herxheimer reaction, where those inflammatory cytokines are produced, making you ill. Another clue that you may have Lyme, but you can have these symptoms with a negative test because of all these other Borrelia species. So we know that Borrelia burgdorferi and miyamotoi can be negative by standard two-tiered testing. And Dr. Lee from Milford Hospital had published this in the International Journal of Molecular Sciences, that he took 20 samples from untreated suspect Lyme disease patients and found miyamotoi in the serum, which was negative for standard two-tiered testing. So in addition, 2 isolates of Borrelia burgdorferi, the more common infectious agent for Lyme, were discovered, in other words, showing seronegativity, that we need more sensitive and reliable DNA-based tests. So if you get a patient with an erythema migrans rash, you can't just say that it's Lyme disease. Now we know that Borrelia miyamotoi in up to 9% of the cases can cause an EM rash, and so does in the United States star eye, southern tick-associated rash-like illness, which may be another Borrelia species, but supposedly causes a milder type of illness. Yet if you spoke to the people in Missouri and in Midwest, they would tell you they don't agree with that. Some of them are quite ill. Now here's a case of someone with Borrelia hermsii relapsing fever in a peripheral smear. You can see the spirochete kind of right in the middle of the slide. Now we had tracked Borrelia hermsii infections in our office last year in 2013. We tested 213 people with known Lyme disease, and what we found is 27% of all of the people who came to me with Lyme disease have been testing positive for Borrelia hermsii relapsing fever. And what we don't know at this point is whether some of these people may in fact be Borrelia miyamotoi or other Borrelia species where there's overlaps on the sensitivity of the test. So clearly these relapsing fever Borrelia is something you should be testing for on a regular basis, and even Borrelia hermsii may be used to suspect a tick bite and that you have different strains of Borrelia. Now, with Borrelia hermsii, you would expect to see these periods of very high fevers, 103, 104 degrees, 39 to 40 degrees centigrade, drenching sweats. You would expect also to see headaches, fatigue, and muscle pain. But just like Lyme disease is known as the great imitator, where it imitates chronic fatigue syndrome, fibromyalgia, autoimmune diseases like MS and ALS, so will relapsing fever, because it can cause, for example, gastrointestinal symptoms, nausea, vomiting, abdominal pain. Normally, as doctors, we would think that would be a virus. Yet you'll see with Ehrlichiosis and Anaplasmosis, there are GI symptoms. The same thing with rickettsial infections, like Rocky Mountain spotted fever. The same thing with Q fever, Coxiella burnetii, where you can get a hepatitis and gastrointestinal symptoms. So when you see different gastrointestinal manifestations, you also must think tick-borne co-infections. And even Borrelia burgdorferi and Borrelia miyamotoi can cause a meningoencephalitis. And we will also see this in other tick-borne infections, such as Q fever and brucellosis. You can get a peripheral neuropathy, neuropsychiatric problems, a myocarditis with arrhythmias. And what is different about this relapsing fever is ARDS. The only other tick-borne infection that's normally associated with acute respiratory distress syndrome is babesiosis. It's been published in the medical literature that you can get a whiteout of the lungs with Babesia microti, but you'll also get it with relapsing fever Borrelia like Borrelia miyamotoi. But also disseminated intravascular coagulation and strokes. And it's now been shown that it can be transmitted to the fetus. So the reason pregnant women need to be careful, and the OBGYNs particularly need to pay attention, is that Lyme disease, relapsing fever, Babesia, Bartonella, they can all be transmitted to the fetus. This has all been reported in the medical literature. So you can get fetal death and spontaneous abortions, premature birth, perinatal sickness in some of these young children. And some people and women will get DIC and even strokes. Again, something you would not expect to see with a Lyme-like co-infection, yet something we need to think about. And it's treated with tetracyclines for 10 days or ibuprofen as if you would treat someone with Lyme. Now, there's a question of these borrelial species, do they really persist in the body? Many of the earlier studies that were done by Straubinger and dogs from Cornell showed persistence of DNA. Monica Ember's study showed persistence of DNA in the macaque monkeys. Hodzik, in the recent xenodiagnostic study, showed persistence of DNA, but what he also showed, what was interesting in his study, it was not just PCR positive, but there was RNA transcription after the mice were treated for Borrelia, meaning it wasn't just dead DNA, the RNA was actually transcribing months later. And in the recent xenodiagnostic study done by the NIH by Adriana Marquez and WHO, they also showed persistence of Borrelia DNA because one of the patients with post-treatment Lyme disease was PCR positive. So the question is, can dead Borrelia persist in the body? And the answer is, if you look at the scientific literature, in the mouse model, any unprotected foreign DNA should be excreted and degraded within 42 hours. You should not be finding positive DNA PCRs weeks to months later. And we have been finding this in our 12,000 patients over the years, especially when they're co-infected. So there is the notion in medicine of bacterial persisters. Persisters are a small fraction of quiescent bacterial cells that can survive lethal antibiotics and regrow under certain conditions, leading to post-treatment relapses. Now, Lyme is not the only disease that does this. It's known in tuberculosis. It's known in syphilis. It's known in endocarditis. It's known in brucellosis. It's known in biofilm infections. So we know that bacteria can persist in the body, and recent studies have suggested that there are a number of genes and pathways that show the mechanisms as to why these bacteria can persist and survive. And these include toxin antitoxin molecules, DNA repair or protection, phosphate metabolism, antioxidant defense, and macromolecule degeneration. And this was just published several months ago by Zhang in Emerging Microbes and Infection in 2014. There's also persistence through immune invasion, because Borrelia, through gene recombination, can modify its surface antigens, VSLE, and non-expressed VLS in gene cassettes, creating these different outer surface proteins and antigens, helping to avoid immune recognition. And that is exactly the same mechanism we see in Borrelia miyamotoi and these relapsing fever spirochetes. That explains how these cycles of every several weeks, how the organism keeps coming out, evading the immune system, and Borrelia burgdorferi has exactly the same mechanism. So as far as persistence of Borrelia miyamotoi, this is an article that is about to be published in an upcoming peer review. Dr. Lee, as well as Dr. Moorcroft and Dr. Lanspin, during just this past winter time, found spirochetemia, positive PCRs, for Borrelia miyamotoi in the blood of patients when they were not being treated for Lyme. This was during winter months after using standard antibiotic regimens. And I found exactly the same thing. I called Dr. Lee at Milford Hospital because I was also finding the same thing as Dr. Lee, positive PCRs for both Borrelia miyamotoi and Borrelia burgdorferi in different patients. One of my patients who was PCR for Borrelia burgdorferi through the same lab had had antibiotics for 5 years without a break. She came to me for a history and physical 6 months ago. I did her blood test, and on the first blood test, she was PCR positive through Milford Lab for Borrelia burgdorferi after 5 years of continuous antibiotics. This is not something that is unusual in my practice. Many of the Lyme doctors in the United States are seeing this on a regular basis. But what was surprising is the ratio of Borrelia burgdorferi to Borrelia miyamotoi infection was 3-to-1. So in many of these patients, maybe 25%, and you saw from my study, 27% of my patients had Borrelia hermsii infections. In his study, it was almost exactly the same. We're finding relapsing Borrelia in approximately 25% of our patients, which evades the immune system by standard two-tiered protocols. Now, regarding Ehrlichia, if you have a patient come into you during the summertime with tremendous fatigue, stiff neck, severe headaches, very high temperatures, with myalgias and arthralgias, and you do a complete blood count and you find leukopenia, low white cell counts, thrombocytopenia, low platelet counts, elevated liver functions with transaminitis, this is very classic for Ehrlichiosis. Now, you want to be careful with some of these tick-borne infections like Ehrlichia, Anaplasma, and even rickettsial infections, which cause exactly the same clinical presentation on lab tests, because they can be deadly and fatal in the very young and the very elderly, especially those who are immunosuppressed. So if you suspect Ehrlichia or Anaplasma, it's very important to start them on a tetracycline like doxycycline immediately, and if they're allergic, you can put them on rifampin. So Ehrlichiosis is caused by tick-transmitted bacteria of the genera Neorickettsia and includes, as Dr. Shaw told you, HSC, HGA, Anaplasma phagocytophilum, HME, Ehrlichia chiefensis, HEE, and HWME, which is found in Wisconsin and Minnesota. The problem is there are no specific tests for certain of these Ehrlichia, and you can get false positive tests for patients with Rocky Mountain spotted fever, typhus, Q fever, Brucellosis, Epstein-Barr, and autoimmune, and Anaplasma has now been found in the blood supply. So they've now in the United States found, through the Red Cross, positive cases of Anaplasma, and I'll show you soon the same for Babesia. So these tick-borne co-infections can be transmitted not just by a tick bite, but they are being found in the blood supply. And there are now studies that just came out several months ago by Dr. Stricker, possibly that there may be sexual transmission. This has not been proven at this point, but 100% of vaginal secretions and 50% of semen was found to contain positive PCRs for borrelia. So we don't know at this point how many different ways borrelia can be transmitted, but the blood supply, it is showing up for some of these tick-borne transmitted co-infections. Now, if you were to get that clinical presentation of a low white cell count, a low platelet count, and elevated liver functions, and you give them a tetracycline, they don't respond, the reason could be that it's not Ehrlichia. They found a virus 2 years ago, which was published in the New England Journal of Medicine. It's a phlebivirus, and they dubbed it the Heartland virus. And it resembles Ehrlichiosis. It's from Ambyloma americanum, the Lone Star tick, and it can cause exactly the same symptoms with fatigue, fever, loss of appetite, but also non-bloody diarrhea. So remember these gastrointestinal symptoms you can see with the vasculitis and rickettsial infections and Ehrlichia can be due to tick-borne co-infections. So it looks like Ehrlichia, but it will not respond. And these tick-borne co-infections are just one part of many tick-borne viruses that are now being found, including tick-borne encephalitis virus, which you have in Europe, and several other ones. We're mainly today going to discuss the deer tick virus and Powassan encephalitis. Now, Babesia is probably the most common co-infection that I'm finding in my patients. And it's the one that is keeping many of the European patients who come to see me and many of the American patients sick. Now, when would you suspect a patient has babesiosis? Well, if they come in with the classical symptoms of Lyme, they have good and bad days. The symptoms come and go. The joint and muscle pain and nerve pain migrates around the body. It gets better and worse with antibiotics. It's changed by hormones. But they say to you, I have day sweats. I have night sweats. I have chills. I have an air hunger, a dyspnea, where I can't explain why I can't catch my breath. I have a cough that I can't explain. They don't have allergic rhinitis. They don't have asthma or COPD. They don't have GERD and reflux, which accounts for 99% of our coughs. That is a classical presentation for babesiosis, especially in a patient that is 3 times sicker and has not gotten better with Lyme treatment. What Babesia does is it makes all of the Lyme symptoms worse. Whether it's your fatigue, your joint pain, your muscle pain, your nerve pain, your memory and concentration problems. We have had resistant patients being treated for Lyme that once they were treated for Babesia, they got better. There was one patient in France who just came to me. She was sick for 13 years, being unable to be helped by French physicians. We discovered Babesia while 1 Duncani. I gave her Mepron, atovaquone, with azithromycin, with Septra, Bactrim double strength. And within 1 month, she said to me, I feel incredibly better. I can now get out of bed. My muscle and joints don't hurt. I have better energy than I've had in the last 13 years. And it was not picked up because they were not testing in France and in many parts of Europe for these different strains of Babesia. So you can get Babesia wild 1, Babesia duncani, and Babesia divergens, all of these different Babesia species, but the problem like Lyme, where there's 100 different strains of Lyme in the United States and 300 worldwide, there are over 100 different types of Babesia called piroplasmosis. And we're not going to pick up all of these different strains of Babesia, so what you need to do is a Babesia panel. The Guillemets stain that most doctors were taught to treat and to test for Babesia will only pick up Babesia if the level of parasitemia is greater than 5% in the blood. You will not pick it up otherwise on a Guillemets stain. We have to use a panel approach of an immunofluorescent assay, a fluorescent in situ hybridization, a FISH test, the RNA probe that Dr. Shaw talked to you about, and a PCR test. And we will find that an IFA can be negative, but a PCR can be positive. Or an IFA and a PCR can be negative, but a FISH can be positive. So if you have a patient with these malaria-type symptoms and they're not getting better, and you've ruled out by differential diagnosis the other cause of drenching sweats, they don't have hyperthyroidism, they don't have tuberculosis, non-Hodgkin's lymphoma, hormonal failure. To discuss differential diagnosis more in detail tomorrow. You must suspect Babesia in these patients, and you should give them a trial of anti-malarial medication. It makes a huge difference in getting many of these patients better. Now, we don't use so much clindamycin and quinine unless we don't like the patients, because it causes nausea, vomiting, a rash, and ringing in the ears. So if you don't like the patients, you give it to them, but otherwise, Mepron, Zithromax, and/or Bactrim double strength is much better tolerated, and people do well. And we also find that clindamycin and a macrolide, like azithromycin or roxithromycin, which is used in Europe quite often, will work very well in these patients, with Malarone, atovaquone proguanil, as opposed to just Mepron, because there's Mepron resistance in the United States. Dr. Peter Krause, who has done a lot of the prior studies on Babesia, published in the New England Journal 2 years ago, they're finding Babesia resistance to atovaquone, Mepron in the United States. I don't know in Europe, but this is something you definitely need to look into. And we combine it generally with herbs like Artemisia, because we find that a lot of these malarial parasites have become resistant to treatment. So as I said, the genus Babesia comprises over 100 different species of these different protozoal pathogens. And we found, as I said, that while one Babesia, duncani, is now almost 20% of the patients who come to see me, and even our CDC in the United States are not tracking these patients on a regular basis. Babesia is now in the blood supply. The Red Cross in the United States is very concerned. So this is, again, something you need to consider in an immunosuppressed patient. This is one of our patients that we did through IGeneX laboratory. This is the fluorescent in situ hybridization test, the FISH. And again, it kind of looks like malaria, where you get these Maltese cross ring forms, just like you'll get with malaria. One thing I want to tell you about, and this just got published in Science just this month, we're having a tremendous problem dealing with these tick-borne infections worldwide. The problem with the standard vaccinations is, as I've told you, that one tick bite, you can get multiple co-infections. They just published in Science that NIH researchers have pinpointed a protein in patients with malaria called PFSEA1. You need this parasite, this particular protein, to escape from inside the red blood cells. And they found that antibodies against this protein managed to trap the malarial parasites inside the cells, blocking the progression of malaria. So in 5 experiments, vaccinated mice that targeted PFSEA1 had parasite levels 4 times lower than unvaccinated mice and survived twice as long. And in children in Tanzania and Africa, for those who had spontaneous antibodies against this protein, they did not die from malaria, because malaria is killing 1 child every minute in Africa at this point. And we're finding Babesia, just like malaria, to be the #1 co-infection keeping many of these patients sick. So what we're also looking at in the United States for vaccination strategies is vaccinating the mice. There's a company, Biologics, that is looking at vaccinating the mice, so when the ticks feed off the mouse, the antibodies will kill the spirochetes, and the mice, therefore, and the ticks cannot transmit it to humans. Did this for rabies in the United States years ago. I think we need to look at these type of vaccination strategies. Or a tick spit vaccine, where when the tick attaches, there are antibodies against the tick spit, where it will fall off, because many of these co-infections, as I said, is the reason people are getting sick. To just do a vaccination against Lyme disease will not get rid of all of these other tick-borne infections that are making people sick. We're finding also a tremendous amount of Bartonella in the United States. And as you'll hear also from Dr. Byard later on, many different species of Bartonella are very difficult to catch. Now, you learn in medical school that typical Bartonella will cause a small papule and enlarged lymph nodes, and you might get a headache and some fatigue. But the problem we find in patients with Lyme and Bartonella, or Lyme Babesia Bartonella, is that, again, they're much sicker. They get chronic demyelinating peripheral neuropathy, or radiculitis, transverse myelitis, vasculitis, very bad eye manifestations with neuroretinitis, sarcoid-like presentations where you can get mediastinal lymph nodes that are enlarged on a chest x-ray, and you might think is sarcoid, but you treat them, and in fact, it was Bartonella. And I've had one case with this who had a negative find test through Mount Sinai. He did not have sarcoid, and in fact, it was Bartonella causing the symptomatology. So as I told you earlier from this woman who could speak, Bartonella causes tremendous neurological symptoms. So if again you have a patient with very bad neuropathy who is failing standard treatments, very bad encephalopathy with tremendous memory and concentration problems that are failing standard treatments for Lyme, that even in Brian Fallon's NIH double-blind study, one of the patients with Bartonella who failed IV Rocephin did very well with Bartonella treatment. And this is what we're finding in our patients if we use double intracellular regimens like doxycycline and rifampin, a macrolide, which hits the 30S, 50S ribosomal subunits, or doxycycline and a quinolone like ciprofloxacin. When you combine these double intracellular regimens, we find many of these resistant patients who fail Lyme treatment, who fail Lyme Babesia treatment, will get better. Because again, Bartonella as a co-infection making them sick. There are some unusual rashes with Bartonella. We don't see them that often, but we do occasionally. Now this one actually is a bit unusual because usually it's not in the skin planes. It's usually transverse in these patients, but we've seen these type of rashes go away in patients for Bartonella. The other problem, as I said, is Bartonella was now published by Dr. Braithwaite several years ago in Clinical Microbiology that it can be transmitted from the mother to the fetus. And the same thing has been found with Lyme, relapsing fever, Babesia. A German patient who came to me recently in her 3rd trimester developed drenching night sweats. She tested positive by a Babesia fish, and we treated her in the 3rd trimester with Mepron, with atovaquone and Zithromax, and fortunately the baby, when the baby was born, did not have hemolytic anemia. And there's very few cases in the medical literature. It was published years ago in the New England Journal that the 3rd trimester you can use drugs like clindamycin and quinine, but there's not that much in the literature. But we have found that atovaquone and Zithromax is safe in pregnancy. What about Mycoplasma fermentans? Years ago, we took over 700 patients in my practice, and we did PCR analysis on these patients. And what we found is up to 13% of my patients in the blood were testing positive for Mycoplasma fermentans. Now, it's very difficult to know the exact role of this particular Mycoplasma species, but it's been associated with Gulf War syndrome and with certain autoimmune manifestations. So it may be responsible for some of these patients who develop chronic relapsing symptoms. And the problem is on standard immunofluorescent antibodies, you will not pick up this particular form of Mycoplasma. So you use the same intracellular drugs, tetracyclines, macrolides, quinolones in combination. We find it can be effective. But here's what I find very interesting about Mycoplasma infections. Tomorrow I'm going to show you on the 16-point MSIDS map, there are 8 different reasons why people could get inflammation. Increases in tumor necrosis factor alpha, interleukin-1, IL-6, interferon gamma. Mycoplasma species specifically have been shown to interact non-specifically with B lymphocytes, resulting in autoimmunity and causing rheumatoid diseases. And this is published in the medical literature in clinical infectious diseases. They also increase pro-inflammatory cytokines, including IL-1, IL-2, and IL-6, and they've been found in the joint tissues of patients with rheumatological diseases. So if you're a rheumatologist and you had a patient who you gave Plaquenil and minocycline, which they will call a DMARD regimen, a disease-modifying anti-rheumatic drug regimen, and they give you Plaquenil and minocycline, they'll tell you it's working because of its anti-inflammatory effect. But minocycline has an effect on Lyme and Mycoplasma species, as well as many of these other intracellular infections that may never have been tested for. And that's what we're finding in a lot of these patients. Other important co-infections that we find are Rocky Mountain spotted fever, Q fever, and typhus. With Rocky Mountain spotted fever, it's very nonspecific initially, gastrointestinal symptoms with fever, nausea, vomiting, and headaches. And the rash that is classic for Rocky Mountain spotted fever may not appear until after the 6th day on the palms and the soles of the feet. Just like Ehrlichia Anaplasma, you can get leukopenia, low white cell counts, thrombocytopenia, low platelet counts, and transaminitis with elevated liver functions. And again, it can be life-threatening. Tetracycline should be started immediately. Now, Q fever, Coxiella burnetii, we are finding a tremendous amount in my patients. What's interesting about Q fever is that it's the great imitator, just like Lyme. 50% of the cases, you will not even get classical clinical symptoms, but it can cause a chronic hepatitis. It can cause a pneumonia and a pneumonitis. It can cause meningoencephalitis, just like Lyme, and relapsing fever, as well as a chronic endocarditis, just like Lyme. So if you have a Lyme patient and you hear a murmur, you should think about doing an echocardiogram and a transesophageal echocardiogram in these patients, checking for Coxiella burnetii for Q fever, and making sure that the phase 2, phase 1 antibodies are not high and that this patient may have been exposed to Q fever. We found a few cases of tularemia. One patient who came to me from the southern part of the United States had huge ulcers on his leg nodes, and he had retroperitoneal fibrosis. He had shut down his kidneys. He had had stents and went into renal failure. He went to major hospitals. They did a colonoscopy thinking that these ulcers might have been due to pyogranosum gangrenosum, that there was some other infection that was causing it. It turned out he was a chef and was working with rabbits and had been exposed to tularemia. He also had drenching night sweats. He had babesia. He had migratory joint pains. He had Lyme disease. And once we treated him for all the different co-infections, for the first time in 5 years, these painful ulcers cleared up and his retroperitoneal fibrosis went away on a CAT scan and he regained his kidney function. These are the kind of cases we're seeing with these multiple co-infections that are showing up in patients all the time, and even Brucella with high fevers and weight loss are showing up in a very small percent. It was published in the United States in the Midwest that 10% of the patients with chronic fatigue syndrome in the Midwest will test positive for Brucella. And this is not something that many doctors are looking for. There's also all of these viral infections. Now, you can get patients who've had prior viral infections. For example, now in the United States, we have the new tiger mosquito, which is spreading and contains 20 different viruses and pathogens. So some of the patients who come to see me have been exposed to West Nile virus, and then they get Lyme disease, and they get much more ill. So the tick-borne encephalitis virus is one of the ones that's in the ticks, just like the Heartland virus that we discussed. And here in Europe, you definitely have some of these encephalitis viruses. And the question was asked earlier, well, what about these other viral infections? We do find that some of the prior viral infections will reactivate when the immune system has been suppressed with Lyme and multiple co-infections. So some people get elevated herpes virus 6 titers, reactivation of Epstein-Barr, and even cytomegalovirus, which has been published in the literature to cause tremendous rheumatological reactions in some of these patients. Powassan virus is particularly difficult because now that we know that in our area up to 5 to 6% of the ticks are containing it, it can cause a deadly encephalitis virus. It was first identified in Toronto in a fatal case of encephalitis, and there are 2 lineages of this tick-borne virus, lineage 1 and lineage 2, which is the deer tick virus that we're normally seeing. But we've now found it in the Northeast, in New York, in Massachusetts, in Connecticut, and the virus was isolated in about 5% of the adults collected where I live in New York State. This was just published in Parasites and Vectors in 2013. So Powassan encephalitis is a bit different than Lyme, where we normally think it could take several hours to transmit this organism. It's been shown with the Powassan virus that within 15 minutes of a tick bite, you can get this virus into your body and can cause an encephalitis, causing fevers, causing seizures. Now, the only other tick-borne infection that we usually will see seizures, new onset seizures, is Bartonella. Bartonella will cause new onsets of seizures in patients, and rarely we will see seizure disorders in patients who have Lyme disease and Bartonella. But patients will lose consciousness. They can get hemiplegia with very difficult neurological sequelae. We can look for serum and CFS Powassan virus-specific antibodies and look for it by PCRs. But if you do an EEG, they will have a diffuse encephalitis and demyelination on MRIs, and there's no treatment at this point in time. They're looking at HIV medications, but unfortunately the fatality rate is 10 to 15%, and in a study that Dr. Wormser is working on right now, up to 30%. So the differential diagnosis, when you know that you can get all these different tick-borne infections, Lyme has this classical presentation of coming and going. The joint and muscle pain and nerve pain moves around the body. It doesn't have to, but often it does. Women will flare up around their hormonal cycles. People get better or worse Herxheimer reactions with antibiotics. When they have Babesia, they're much sicker with these malarial type illness. With Ehrlichia Anaplasma and Rickettsial, low white cell counts, low platelet counts, elevated liver functions. And then we have Mycoplasma Chlamydia, also probably causing an underlying role in some of these patients, and even certain Candida and yeast syndromes that may be causing problems in some of our resistant patients. So in diagnostics, the key point is Lyme is a clinical diagnosis. Even the CDC in the United States said that the two-tier testing is for health departments to epidemiologically screen large populations. The CDC on their website said, do not use the two-tier test to make a clinical diagnosis. This is on the CDC website. What they have said, it's for screening patients epidemiologically. So it is a clinical diagnosis where you want to look, as Dr. Shah told you, for those borrelia-specific bands on a Western blot. The 23, the OSP-C, the 31, the OSP-A, assuming again it's not from another protein, or that they've had the Lyme vaccine. The 34, the OSP-B, the 39, and the 8393. So if I have a patient who've tested negative by ELISA, and in my patients, most are negative by ELISA and positive by IgM Western blot, because Steer published on this years ago, you saw the reference, back in the 1980s, you get frequently positive IgM Western blots in patients with chronic Lyme disease, and not always in the early stages of the disease, because it can take weeks before you make an IgM antibody. So you look for those, and then you look for PCRs. You can use the lymphocyte transformation test and culture test in patients where you clinically suspect it, but you've not been able to find it. So we really need reliable blood tests because of the sensitivity of the ELISA. The ELISA has approximately a 50% sensitivity. I will show you tomorrow more of the studies on this, and I know Dr. Perun will talk about this later on. And you need to look at laboratories that expand the strains of Borrelia, because if there's 100 different strains of Borrelia, you cannot expect to find it on one Western blot that's using just the B31 strain. And in France, there was a laboratory that was using multiple strains with Abzelai, Guérini, Spilmani, Valsana, and what we were finding in the French patients who came to us, their tests were often positive for many of these other borrelial strains in Europe that were not testing positive by the French labs because, as Dr. Perun will explain to you, there's a problem with the sensitivity of the test. So we need to look at babesiosis in Europe. I'm seeing it quite a bit in the European patients coming to see me. And you need to check for other parasites, because I'm finding when you have Babesia, these intestinal parasites are causing people to remain ill, and some classical anti-parasitic protocols are making some of these resistant patients better. And then again, look for all of these other tick-borne infections. So the key points in treating is if Lyme disease has a cell wall form, and a cystic form, L forms, S forms, cell wall deficient forms, which again, Dr. McDonald and Dr. Shoppy will talk to you about. And it goes inside the cells, and it's in biofilms. If you just use one antibiotic, you're not going to cover all the different forms of Borrelia, which can change forms. So our approach is to use, for example, a cell wall drug, like a penicillin or cephalosporin, combined with a cystic drug, like Plaquenil, grapefruit seed extract, tinidazole, Flagyl. I was the first physician who discovered Flagyl's use in Lyme disease, and interestingly enough, in Norway. Dr. Brorsen, 6 months after I was at the International Lyme Conference in 1999 talking about Flagyl for Lyme disease, Dr. Brorsen in Norway did the first study showing that Flagyl hits the cystic forms of Lyme disease. And I called up Dr. Brorsen and I said, thank you to Norway, because I didn't understand why Flagyl and tinidazole was helping some of these patients. So the Norwegian researchers have been essential in helping even us in the United States to figure out some of these different effects of the antibiotics for Lyme. So we will combine this with biofilm busters such as serrapeptase, nattokinase, EDTA, and we get much better results. But if you have Bartonella, Mycoplasma, some of these intracellular infections, we found that single drug intracellular therapy will not clear it. Patients have come to me from other doctors after 1 year of treatment with a tetracycline, and they're positive by PCR in the blood for Lyme disease, Bartonella, Mycoplasma, and Babesia. Those 4 infections are the ones that I'm finding are chronic persistent infections, and usually when people are multiply co-infected, as I said, the immune system is suppressed. So if you combine these double intracellular regimens, we find it to be much more effective. Doxycycline, rifampin, and Septra is used for brucellosis. We find that regimen works wonderfully for Brucella and some of these intracellular infections. And if one regimen doesn't work, for example, a patient with severe neuropathy, who's been on Neurontin, who's been on duloxetine, Cymbalta, who's been on Elavil, amitriptyline, neuropathic drugs. They still have pain. They're on morphine, severe drugs for treating pain, and their neuropathy hasn't gotten better. We found that treating Bartonella and treating intracellular co-infections in many of these patients, their pain goes away. It was the intracellular co-infections that were driving these inflammatory cytokine production, making them so sick. So when we're looking at designing these different regimens, there's a way that you can think about combining it, about looking at whether they have Lyme disease, whether they have Bartonella and Babesia, and basically you're looking at combining the drugs for Lyme, and let's say they have Bartonella, you can add Septra, which has also been proven to be effective for Babesiosis, and then you add Mepron. And we find that these combination therapies in the sickest patients are the ones that are working the best, and these are not normally published in peer-reviewed literature, which is why you're not finding these answers. This is what we would love to work with the Norwegian people and the Norwegian government. If you would like to open up a clinic here in Norway, where I show you the type of treatment regimens that we're doing in the United States, it would be my great pleasure to work with you and show you the effectiveness of these type of regimens so we can help the Norwegian people. So again, to finish up, Lyme MSID is a new paradigm for chronic disease. Everyone is talking about Lyme disease, but what's making people sick is not just Borrelia burgdorferi, but all these other Borrelia species like miyamotoi, like the co-infections, and as I'll show you tomorrow, all the different reasons why they have inflammation in the body. So patients with Lyme MSIDs have immune dysfunction, inflammation. They have environmental toxins like heavy metals that cause exactly the same Lyme symptoms. I'm going to show you the studies tomorrow on this. They have problems detoxifying chemicals in the body. They have nutritional deficiencies, hormone abnormalities where Lyme disease affects the HPA axis in the pituitary, and it shuts down the production of testosterone, where the adrenal hormones will go down. And if you look at the double-blind placebo-controlled studies by the CDC and NIH, they only talk about Lyme disease. But what's making people sick are all of these different co-infections and the effect of these infections on the terrain of the body. When Lyme affects the body, it affects the hormones. And you may have leaky gut, food sensitivities, mineral deficiencies. You can't get to sleep. These all cause cytokine production with inflammation, and it's inflammatory cytokines that are causing the fatigue, the headaches, the joint pain, the memory problems. When you lower the inflammatory cytokines, even without eliminating every Borrelia species in the body, these patients will get better. So this is the 16-point map that I'm going to discuss with you tomorrow. We don't need to go into it today, but to finish off, wisdom is the marriage of knowledge and experience bound by compassion. The most important thing in medicine is not simply learning in textbooks and not simply going to talks, but having compassion and exchanging yourself for the patient and saying, if this was my father, if this was my mother, if this was my brother or my sister and they were sick, you would not give up. You would keep looking for answers until these people are better. And if you have compassion with the peer-reviewed science that we've talked about today, patients will get better. So thank you so much for your attention.
Thank you, Richard. We will have 5 minutes for questions. Down there, yeah.
It's Ross here again. I just have 2 quick questions. Would you open a clinic in Washington State? And would you order blood testing for me?
If I could reproduce myself and put myself in many places, I'd be happy to. But actually, I'm looking at this point of trying to replicate the model that we've done in New York. And any doctors who would like to learn the model can come and train with ILADs, physicians, as Dr. Borscano talked about. I'm happy to train any physicians in this model. And if there are doctors in Washington State and Norway who want to train in this model, you can do your own double-blind studies and look at this model and compare it to the IDSA way of treating. And I will show you for sure that the model that we're using will get people better because this model is very inclusive of many infections. So although I personally won't do it, if people would like to work with me to help learn about this, I'm happy to help in any way that I can. And as far as testing yourself, well, that's something you could speak to me about privately.
Thank you.
I would like very much to thank you. This is a wonderful presentation, and I think that everything is inside. All the problem that we have today, all the things that we have to do in the future, everything. Now, I would like to ask you, because of course it's very difficult to introduce so many serological tests, so many detection for, it can be by DNA or others, for so many different co-infections. Indeed, that this would be the most important, and I agree with you. Also with respect to the different borrelia strains, different borrelia species. So we have a lot of things to do, but I think it was just not only excellent, this presentation, but it was the heart inside. Now, I would like just to ask you whether you know, I know perhaps somebody who is working on such things to try to develop a test with small samples so that you can check many different microorganisms. I think this shows very well that we need it. Another thing I wanted to ask you about chlamydia. This is, of course, not a tick-borne pathogen, but on the other side, when we are testing patients, about 80% of the patients, particularly with age, the percentage is increasing, who had also chlamydia pneumonia, and we know that chlamydia pneumonia can also be present together with borrelia burgdorferi inside, for example, in arthritis. So I would like just to say that in addition to the tick-borne, this was your topic, just I would like to tell that there was in Germany a study in which they have shown also that chlamydia pneumonia should be also in our mind. Thank you so much again for this excellent.
Yes, thank you, Judith. Regarding chlamydia and pneumonia, just briefly, Judith McCloskey was just talking about this. In the United States, there was also a published study that when people had chlamydia pneumonia and Lyme arthritis, and they had heavy metals, like mercury, they had much more inflammation. And when you pulled out the heavy metals, the inflammatory cytokines went down. And this was published in the medical literature regarding chlamydia pneumonia, which has also been published on multiple sclerosis. So yes, definitely chlamydia pneumonia. I think many of these infections in the future with autoimmune diseases and arthritis, we're going to find that many of these, in fact, have been caused by infection, but I think many of the environmental toxins that we're also exposed to, and I'll show you the literature on mercury tomorrow, may be causing some of this overlap of the autoimmune phenomenon that we're seeing. But yes, excellent.
What is your experience with bacteria resistance?
My experience is I have not really seen bacterial resistance, but again, I don't treat with just doxycycline. I use combination therapy, and just like tuberculosis, we would use rifampin, INH, rifampin, pyrazinamide. I tend to use combination therapy to hit the cell wall, cystic, intracellular. So if patients come in after months or a year of treatment, and they get a bronchitis or a urinary tract infection, we have never seen resistance in any cases. And I think I met with the Minister of Health in France about a year ago, and I spoke to their country in France, and I spoke in French because I'm fluent because I lived here for 7 years. And she was worried about resistance, and I said, you know that 70% of all the antibiotics we get are from animal feed. They're not from doctors prescribing antibiotics. And I think it's very important to know that yes, resistance is a problem with MRSA and others. We should not ignore it. But we also have to be careful where many of the antibiotics are getting into the system, but I've never actually seen a case of resistance in all the years that I've treated.
In the States,
One last one.
folks with Lyme encephalitis, there are a lot of people now speaking about fungal infections in the brain. I was wondering if you could say anything about that.
It turns out with fungus that it can actually be very important, and I'm going to discuss that tomorrow. But one of the surprising features that we found in the last 6 months is when I talk to you tomorrow about differential diagnosis of memory concentration problems. The problem with memory concentration is you could have hypothyroidism, you could have B12 deficiency, not picked up on standard testing, where you need a methylmalonic acid or homocysteine. You could have other tick-borne co-infections causing encephalitis, but we're finding neurotoxins like quinolinic acid, which can cause the same type of encephalopathy. And when I use glutathione, which is made by the liver to pull toxins out, these patients' memory and concentration problems improve without antibiotics. And regarding fungus, we've now found mold neurotoxins showing up in the patients in 2/3 of the patients who have resistant encephalopathy. Ochratoxins, aflatoxins, trichothecenes, which are very severe mold toxins, are now showing up in some of my resistant patients through a lab called Real-Time Labs in Texas. I'm going to describe this to you tomorrow. That there are these multiple overlapping factors that you could have zinc deficiency causing a backup in your liver in the phase 1 causing aldehydes, chloral hydrate, gives you brain fog. We found ammonia levels to be high. There's quinolinic acid, there's Lyme, there's co-infections. There are all these factors causing memory concentration problems, and even in Alzheimer's patients, when they gave them a tumor necrosis factor alpha inhibitor, like etanercept, and they injected it into the spinal fluid, they found that their memory concentration got better just by decreasing inflammatory cytokines. And I'll show you tomorrow a lot of the studies on inflammation, but you're talking about fungus and mold is actually going to, I think, become one of the major areas of detoxification, because some of the doctors are seeing that some of this resistant encephalopathy is not just from Lyme. It's just the studies were only done on Lyme, but not all of these overlapping factors, and that's why a differential diagnosis is so important in so many of these patients. Yes, excellent question.
All right. I think